Thanks so much. Thanks, Laura, for the introduction. Thanks for having me. So, I'm a geriatrician. As Laura said, in Cork, I trained with Sean and Tala, and like I said earlier, I tried to steal as many of Sean's ideas as possible and bring them south. So I'm on a fact-finding mission as well today. And I'm going to talk briefly about the life course model for brain health. We've heard a lot about that already, so I won't labour it. And then I'll get into the Irish context, talk a little about awareness of modified risk factors for dementia, and what are the barriers to us engaging in these kind of brain health behaviours that we know are good for us. And I think that even the fact we're having this session, like we've seen such an increased focus on brain health and dementia prevention. We've this seminal paper in the Lancet that all of us are alluding to in 2020 that was updated earlier in the summer, essentially saying there's now 14 modified risk factors responsible for 45% of dementia globally. And at the heart of that life course model is the fact that it's never too early and never too late, irrespective of where you are in life, to think about reducing your dementia risk. So we've early life risk factors that impact cognitive reserve, and then midlife and later life risk factors that will impact reserve, but also potentially trigger neuropathological developments, as Sean was saying earlier on. This slide, we've seen it and variations of it already. So early life, something we've very little control over, our level of education. As you move into midlife, and as Yvonne said, that's where so much of the focus is. Cardiovascular risk factors very relevant, but also things like hearing impairment. So less intuitive risk factors that I'll talk about now in a little bit more detail. In later life, it's social isolation, air pollution, and visual loss has recently been added. Hearing impairment is something that we've known about for a while, but still remains quite under-recognised as a risk factor for dementia. Even really subtle levels of hearing loss are going to impact your cognition. So for every 10 decibels of hearing you lose, your cognition will measurably go down. And a whisper is 25 decibels. So I say even a fraction of a whisper, your cognition may start to dip. From big studies in the States, it really seems to relate to the severity of your hearing loss. So mild hearing loss, there's an association. Severe hearing loss, you're significantly more likely to develop dementia. Work from Sean and the team in Tala suggests that this is really common in a memory clinic setting. So when they asked people with mild memory issues about hearing, about 40% of people thought they had an issue. When they tested it, it was about 85% of people actually had objective hearing loss, and in half of those, it was moderate to severe in nature. The good news, and what we emphasize in clinic, is that hearing aids are protected. So particularly if you're someone at high risk, if you're someone with a lot of vascular risk factors, diabetes, high blood pressure, and you've hearing impairment, wearing a hearing aid really seems to work in diminishing your risk going forward. Something that's novel, that hasn't come up, it's not in that Lancet paper, that current model, but it may well find its way in the next iteration, is vaccination. So there's a rapidly growing body of evidence that common adult vaccinations reduce your dementia risk. Again, these are mainly observation studies, but you have big studies from the States looking at over 120,000 veterans. So even the flu vaccine, so one flu vaccine is good. Sequential flu vaccines, consecutive flu vaccines over a 4-year period will greatly diminish your dementia risk going forward. That's replicated in studies as far away as Taiwan when they looked at people with COPD. Closer to home, the shingles vaccine, that's a little bit controversial in Ireland, in that it's licensed, but it's not, as far as I know, included in your routine schedule of adult vaccinations. There was a lot of talk about it earlier this year. Data from Wales, where they looked at before the shingles vaccine came in, then after the shingles vaccine came in, it does seem to be an independent risk factor. Getting the shingles vaccine diminished your dementia risk by up to about 40%, potentially more effectively for vascular dementia as opposed to Alzheimer's. We don't quite know why that is, so an infective episode, a bad flu, COVID, the shingles, could potentially impact your cognition in that it may increase your delirium risk. It may increase neuroinflammation in your brain, but the effects may well be more non-specific or off-target effects of the vaccine, where essentially it's training your immune system, reducing inflammation globally, and reducing neuroinflammation that could be involved in dementia pathogenesis. So a really interesting emerging area. In an Irish context, we worked with the team in Tala, and I suppose there wasn't actually a lot of information about how prevalent are these modifiable risk factors in Ireland. How aware are we? Do people actually know that these represent modifiable dementia risk factors? And as I said, what are the barriers? What's stopping us from engaging in these behaviours? The results of our studies, so there's 550 people included. pretty much 1-to-1 female to male split. The mean age was about 60, and the majority were of white ethnicity, a highly educated sample, the majority being to secondary school or university education, and the majority were actually still employed and still working. Unsurprisingly, risk factors were really prevalent. This is them in order of decreasing prevalence. So over half the sample, 60% were obese, about 55% of people said they had low social interaction, close to half said that their levels of physical activity were low. The least common risk, unsurprisingly, was head injury, so very few people exposed to activities with a risk of head injury. And I suppose the interesting thing, we did another statistical analysis, a cluster analysis, that showed that it was people of lower socioeconomic status, be it low education, low household income, were disproportionately exposed to loads of these risk factors. We then looked at awareness, and I'm sorry, this graph is a little bit dense, but essentially as you move down, awareness increases. So as you move down, awareness increases. So 90% of people we surveyed knew that head injury was a dementia risk factor. About 85% said low mental stimulation could be a dementia risk factor. Alcohol excess, about 77%, but only a third of people identified hearing loss as being a modifiable dementia risk, despite it having, as we know and as I've illustrated, a really profound impact. We tried to tease out what predicted awareness. So was it gender, was it age, was it education? And the biggest thing that shone through really was education. So people who were highly educated, and that's people educated at university level, far more likely to know that these were risk factors for dementia when we asked them. Barriers, the barrier data was really complex and really highly individualized, and it's very hard to display graphically in an attractive fashion. And so barriers vary between individuals, but then really vary between risk factors. Lack of motivation, perhaps unsurprisingly, came through for lots of the cardiovascular risk factors. So exercise, diet, alcohol, smoking, people just not being able to generate or not having the motivation to actually change behavior was a consistent theme. Practical factors came through for things like low mood, diabetes, hearing impairment, and that's not knowing how or where to seek help with those things. Lack of knowledge wasn't as common as we thought, but it did shine through for risk factors like blood pressure. How to change my lifestyle to control my blood pressure? People just didn't have that knowledge. Solutions, I think in one theoretical, in a sense, solutions are straightforward. You know we have robust targets, we have robust evidence to say you need a tightly controlled blood pressure, you need good cholesterol, you need to exercise, we need to treat your hearing, we need to treat your vision. We need to address those. They weren't 12, now 14 modified risk factors. And I think if you go to a clinic, if you meet Sean in a brain health clinic, if you meet Claire or Joe who were here earlier on an individual level, if someone comes in with normal cognition or really subtle issues, we'll try and address those and develop a kind of a personalized prevention plan that someone can take away and work on. Problem is that's really resource intensive to sit down with someone and comb through those individual risks. And I think we're facing a situation that Sean had a similar graphic earlier on, where in Europe and in Ireland, dementia prevalence is really increasing. And current services appropriately are geared toward people with memory issues, people with dementia. And I think there's a recognition that if we're to impact brain health on a population level, we need to shift that model. We need to be dealing with people who are cognitively normal, who are curious. The terrible term, the worried well. Someone who might, oh, do I have an issue? Maybe I do, maybe I don't. They're the people we need to be seeing if we're going to tangibly make a difference. And this kind of new model for brain health services is operational, as far as I know, to a degree, in places like Scotland, which are 4 pillars: your risk assessment, communication of risk, developing that personalised prevention plan, and then potential measures to enhance cognition. I think, the biggest barrier, and thus probably the biggest solution from a brain health point of view, is awareness. We've had lots of really laudable and commendable brain health awareness campaigns spearheaded by some of the people in this room, but I think we're not quite there yet. So we asked people as part of our work, we asked, do you think you can reduce your dementia risk? Two-thirds of people said yes. We asked, can you prevent yourself from getting dementia? 1/3 of people said yes. So I think we've this really interesting disconnect between the concepts of risk reduction and prevention. And there's still a kind of a feeling out there, God, no, that's inevitable, dementia is part of aging, or some sort of inevitable fate that awaits me. That isn't the case. And we need to get that prevention message out there if we're to make a difference. Claire, who spoke earlier on, had very similar statements, so it's good we're on the same theme. I think we do need targeted public health campaigns, and I think we need to target those high-risk groups. And when I say high-risk groups, I think the lower socioeconomic status groups is where we're probably going to get bang for our buck, because that's where awareness is poorest and risk factors exposure is greatest. And I think that focus on prevention, so moving away from risk reduction, I think the concept of actually preventing yourself from developing dementia is much more tangible and much more actionable. The take-home messages for me, so as I say, the life course model that we've all spoken about, never too early, never too late in life to consider dementia prevention. We've got really robust evidence now for simple lifestyle changes. Barriers are so individualized and complex, but if we're to succeed, I think it's the high risk group that we need to target. So that's it. Thank you.